Maybe Massimo, can you come up to the stage? While we're waiting for the questions from the room, you didn't touch a lot about immunological biomarkers, Massimo. Can you? Immunological biomarkers, yeah, which are not well standardized, obviously.
Do they exist?
Maybe we ask Adam. He's standing at the phone.
Let's ask Adam, and after I can elaborate on his answer.
Yeah. Well, I mean, I think, Massimo, you touched on it. I think these mechanisms of action, biomarkers exist for the immunological drugs. Biomarkers for prediction of functional cure do not, right? So immunological biomarkers related to prediction of what the response is going to be, I mean, we're still looking for those, but we can definitely measure target engagement.
And Adam, going around on the same line, when you say that you have biomarkers for the drugs, for the approach, what are you talking about? Cell-based assays, or we do have something that can be more easily measured in terms of serological biomarkers?
Yeah, great to clarify that. Thanks, Massimo. I mean, for the innate immunomodulators, it's very straightforward. You just take some plasma and you're looking for cytokines that are induced to this mechanism of action. So this is quite straightforward. For therapeutic vaccines, checkpoint inhibitors are way more complicated. It gets into pretty sophisticated cellular-based functional T-cell assays, B cells. Some of it you can measure with anti-HBs potentially in some of these vaccine studies, but even there it's not predictive of S declines in a lot of these vaccine studies too, right? So, it really depends on the class of drug that you're talking about.
Harry, imagine that I was saying all this, I agree.
Adam, you had a question as well?
I do. I have a question, and maybe Grace, you can start with this, and I'd like to hear other comments as well, is these flares during studies, we know if they're good or bad, if you want to use those terms, after the fact, right? So you can't, and this is, I think, a real challenge, and we actually just had a study published in JID looking at different types of flares, acute patients with E seroconversion, and patients that flared after stopping antiviral therapy. And immunologically speaking, looking at these cytokines in the plasma, there was a lot of overlap between them, so we couldn't actually tell what was a good and what was a bad flare. Do you know, what about these viral biomarkers or clinical biomarkers? Do we have any better opportunities to predict the outcome of these ALT elevations?
Okay, thanks. Yeah, thanks for a very important questions. I fully agree this is a very challenging situation. And as you said, usually we only know after everything gets settled and so on. I would say by far the probably most helpful biomarkers would be surface antigen level, because most of the time if surface antigen can also drop during or after the flare, then it will be usually pointing towards something good. And also other biomarkers as described by the previous speakers, be it HBRNA and also like Korean antigen. I think it really depends on the mechanism of the molecules. I think that may also be helpful, but at least consistently in different types of drug trials or even in others like conventional treatment, I think still, I believe surface antigen change during the flare would be most predictive, because usually if it is good, bad flare, then usually surface antigen would not really drop and sometimes even goes up. But for the other way, for good flare, usually the surface antigen would consistently drop throughout the process. So sometimes I will even hold my hand to allow the ALT flare a little bit as long as there's no decompensation, as long as the surface antigen is dropping.
But if I may jump in here, Grace, I agree, but this is again, as Adam mentioned, so this will take some time because you need to know what is happening to S antigen. And the key question for us in the clinic will obviously be, what do we do if a patient has suddenly liver enzymes of 500? And we would like to know at that time what the outcome is. And Adam, I completely agree. I think we need here really very naively a very broad screening for everything that is available on cytokine and cell death level, whether not something can really differentiate, whether something is associated with induction of some beneficial immunity, or whether this is really toxicity. And I'm actually surprised that we have not done that yet in the trials that have available, or at least I don't know about this. and it should be somehow possible already to differentiate somehow the type of death and the course to get an idea. I don't know.
Yeah, I think Heiner, you pointed out a very important point. In fact, I guess there will be a lot of things being explored at this moment, but probably as Adam just pointed out, there will be a lot of overlap, so there's no very clear cut. But I agree that in some patients with good flare, they tend to have better immune response. So I believe that many experts, immunologist experts, will know some particular markers. For example, the cytotoxic T cell response would be better. So I fully agree that we probably need something better to really predict ahead, not really already things happen. So yeah, I really love to see more data from the current drug trials. Yeah.
I'd like to just chip in with my comment, or my thoughts anyway, so I wanted to get yours first. So, you know, these nucleoside withdrawal studies are really the best opportunity to kinetically study this, right, in temporal region. And you know, and I really think we have to start looking beyond viral or immunological biomarkers to some maybe more physiological biomarkers that we hadn't thought of, you know, platelet activation or lipids or something that's not sort of standard measurements of care, because we haven't found anything with our standard measurements in the clinical diagnostics or even in cytokines for that matter. Thank you.
And just to elaborate on the last thing that Adam said, the new biomarkers do not add so much in terms neither to diagnostic, good versus bad, nor in predicting what happens later on. The few data that are in a couple of publications show that they move, but actually there is no common trend or something that you can really derive. So we are still far from having a good biomarker for the flares.
So we have a question from the floor, Heitel.
Yeah, Massimo, it's for you. So the circulating RNA, you said there, you know, from the meeting and from today's talk, you said there's, you know, the extracellular vehicle containing RNA, right? So those RNA, what's the ratio between those EV RNA and the RNA in the virion-like particles? So if you treat those with CPAM, does the ratio change?
We do not have, I think, enough data already to be sure of the ratio, but is a minor proportion. In vitro is 10%, I would say, but Delphine Bosquet, if she's connected, she can correct me because she has the real numbers. She presented during the meeting. And in vivo, very few patients were done. There are, but are a minority. So we know that they are there. I would say that probably we will end up with something that is in the range up to 10%, 50% in few patients, but we do not have enough patients to say. So the big point is whether they will interfere with the different assay we have. And that is the only important point. If it is 3%, probably will not interfere with the interpretation of the data. 15% might be, but we have to check. We have to work more on that. I think this is a very active focus in our groups in Lyon, and I think many others.
So
you know,
I have
one, if I can jump in, I mean, I don't know if you hear me. One of the interesting finding with this exosome containing viral RNAs is that if they are not affected, for instance, by CPAMs, contrary to the virion containing viral RNAs, then it could be a very interesting compartment to study, because this could reflect not the target engagement this time, but the real endpoint, whether we affect the intrahepatic viral reservoir. I mean, obviously this is just a question. We have no data on that, but that could help resolving, at least for some drugs, some mode of action, the issue how to differentiate a biomarker in terms of target engagement versus the endpoint and reflection of the viral reservoirs in the liver.
And Fabian, you are perfectly
needs to be done.
You are perfectly right. Actually, according also to your suggestion, I left the exosomes there in the figure with the cams. But the point there will be whether we will be enough sensitive with our assay to really measure this residual stuff. So we have to do the work. It's quite important. I agree with you.
Okay. I have a question for you, Heiner. This is my annual question, and we haven't seen each other for a while. So, bulevirtide is now being used for a longer period of time. You start off giving PEG interferon and Merclodex at the same time, and then you just continue. Is this going to be a curative or a suppressive treatment? And if it is curative, how long should we treat?
Yeah, so first of all, and I always give my same answer. So I think
so there's no follow-up data?
So I think in 2 or 3 or 4 years, we have 3 different groups of patients. The one group is where we go for bulevirtide monotherapy maintenance treatment. So patients with advanced cirrhosis, you don't want to take any risk, and you just go ahead, and that's what we're going to do. And the second group will be, yes, there will be a combination or there will be a finite monotherapy with bulevirtide. And the answer will come from the 301 trial, which is currently ongoing, where 2 versus 3 years, 2 versus 10 milligram is currently studied. And the third group is what you are talking about, that will be finite combination therapy with interferon. But thus far, we have off-treatment data of 15 patients for the 2 milligram arm. And that's where 7 out of 15 had this response. That's all what we have. There's some, let's say in France, Fabien may comment on that one, in their ANIS program, there have been this and their kind of treatment, also some combinations, high dose, but not very standardized. I haven't seen really off-treatment data. In our hands, I do not use bulevirtide with interferon outside of clinical trials at this stage, because also in the high dose group, every patient relapsed, even though there was a synergism on delta RNA on treatment. And therefore, whether there is really this dose effect as antigen 2 versus 10 milligram, this needs to be confirmed. You have seen the data on the 204 trial at EASL, the short-term treatment. There we couldn't see really a big difference in S antigen until week 24. We just need more data. And therefore, at this stage, monotherapy in Europe, unless we know more about the end of treatment.
Okay, thank you. I have a question for Grace. This is the standard question that we're supposedly asking all of the presenters, because this is a combination therapy mechanism talk. If you were going to be having your ideal curative therapy for HBV, what classes of new drugs would you like to see used together?
Right, yeah. I guess it would be like the previous speaker also pointed out that, yeah, I don't think we have a definite answer yet, but I would very much like to use a different mode of action. And usually I would say that my preference would be at least some would be immunomodulatory and some would be direct acting antiviral, or to really block the viral replication at different level. Probably maybe at the end of the day would be, I guess, maybe 3 drugs at least to work together to really block this HBV cycle at different steps. So I think that may be my preferred regimen.
Thank you. All right, so thank you.
I may have a final question for
of
Heiner.
course, Fabian, rock and roll.
A question for Heiner, because on the drugs developed for HBV that work on HDV, so we have the example of bulevirtide, and now the question is for siRNA targeting HBV. Do you think that they have any promising future for Delta? And what do you think in terms of combination would be the best? Bulevirtide plus lonafarnib, siRNA plus lonafarnib, or the replica compound? Just
okay. Okay, so I have now how many minutes? 15 minutes, 20 minutes for my answer? No,
2 minutes, max.
No, the point is there, and in clinicaltrials.gov, you can see that indeed this has already been studied. So there is trials that have been initiated exploring siRNAs in Delta, and it will be really extremely interesting to see data from that trial. What will be the outcome? You have, you can imagine lowering S antigen should reduce delta also in parallel. And the question is really, however, as we have learned from the siRNAs, you see this decline, then we saw the plateau in the monoinfection. And then is this plateau in monoinfection still, if you would use it in delta, giving enough space for enough delta replication, right? So that's, I think, something we really have to see. And there's a lot of speculation, but we just have to see the answer there. And then obviously, and also from a practical point, it would be cool. So bulevirtide, you have to inject on a daily basis. If I would use a maintenance as siRNA treatment for delta, with once monthly injections would be practical. But so I think we have to see it. And then in terms of combination, Fabien, I think that's too much for a 30-second answer. You can explore and yeah.
Okay, thank you. All right, so we're going to have the excitement coming from reading the results of our second quiz here. And remember, that's for your e-antigen negative non-cirrhotic chronic patients treated with NUCs with DNA fully suppressed in serum. What criteria to use for stopping treatment? 6% say they never stop treatment. This is a lifelong therapy. I'm kind of pleased to see that the majority of the respondees are considering that this will be eventually a terminatable therapy. 58% said I consider to stop NUC treatment if HBsAg is consistently negative. 28% say they can do it if HBsAg is dropped below 100 international units per mil consistently, and 8% said they would consider stopping NUC treatment as long as the DNA has been negative for long enough, again, not defined what long enough is, regardless of what surface antigen is doing. So those are our results. Thank you.
All right, this concludes this session. Thanks so much to all of the speakers and to the audience for asking questions.